Good morning, everyone. Thank you for coming. Welcome to the third annual UCSF Stanford UC Berkeley Global Health Economics Colloquium. I'm Kazi. I'm a cardiologist at San Francisco General and a health systems researcher here at UCSF. We know that this event is organized under the leadership of GHECon, who's the director of GHECon, Global Health Economics Consortium, as we like to call it, GHECon. Doug Owens, who's the director of the Center for Health Policy and Center for Primary Care and Outcomes Research at Stanford. We named the street after him. And Dean Steph Bertossi from the UC School of Public Health. So thank you very much. I want to start out with a few special shout outs. We are delighted to have in our midst Mark Sculfer from the University of York. He is our keynote speaker and is here from England to talk about his experience with the National Institute for Care and Excellence, as well as more recently with the Gates Foundation. So thank you for coming all the way. 3 people have been key supporters of this institution since its beginnings, now 4 years ago. Claire Brindis from the Institute of Health Policy Studies, Paul Volberding, and Jaime Sepulveda from GHS. So thank you very much for everything you do for GHECon and also for UCSF. No, really, we're very grateful. Of course, this event would not have happened but for the tireless efforts of a few people. We usually do thank yous at the end of the day, and I think they're the ones that deserve the lion's share of the credit for making today happen. Devin McCabe, we could not have pulled this off without you, so thank you very much. Jay is helping us with videography this morning. Felix helps us with IT, and we have a group of interns who are helping us run the show today, so thank you very much for all your help. Now, it goes without saying that in the economic turbulence of the past decade has brought us to a very cost-conscious world. So policymakers and donors are still willing to invest in healthcare, but they clearly demand to know whether what they're spending on is good value, whether they're getting a good return on investment. And which is great for those of us who work in global health economics, because it means there's an increasing market for our work, but it also means that our work is being scrutinized more closely. And I think there is a sense in the community that there are 3 key refinements that the field needs to adopt if it is going to continue to stay relevant in the long run. So the first is that we have to have an honest conversation about how we measure efficiency in global health investments. What is working, what is not working, and then when we acknowledge things that are not working, we've got to go forward and address those gaps. So it's no longer sufficient, for instance, to say that the World Health Organization thresholds don't work, because they don't. But we've got to come up with an alternative that does. And Elliot is going to help us with that this morning. The second refinement is that we have to push ourselves out of the comfort of the hallowed world of academia. It's no longer enough for us to publish articles in high-impact journals in a language that only we understand. If we are going to be influential, we're going to have to move out to the dirty world of practical implementation, ask timely and relevant questions, and understand how we're going to disseminate our results in a way that our stakeholders find accessible. And the third refinement in my mind is that we've always acknowledged that decision-making is about more than efficiency. There are other considerations that are important, such as disparities or addressing financial protection, but it's always been in the limitations section of a long article. And I think it's time for us to embrace those limitations and say, how can we incorporate those considerations into the process of economic evaluation to start with? As some of you might know, today is Abraham Lincoln's birthday. And it gives me great pride that for the first time, we have a colloquium session dedicated to addressing things that matter beyond efficiency, such as disparities, financial protection, and a sensitivity to the global budget of health systems. So I'm really excited about that session this afternoon. And finally, if you are tweeting, then the hashtag is GHECon 2016. As they say in Silicon Valley, if people aren't tweeting about it, did it actually happen? So with that, I'll welcome GHECon, Doug Owens, and Steph Bertossi to get us started.
Thanks, Kazi, for a great introduction and overview to the day. I would just like to say a word about GHECon at UCSF over the last year, 2015. And it's been a very exciting period for this still young effort. Most importantly, I think, we succeeded in signing a cooperative agreement with CDC to look at economic analyses across 5 different disease areas, and very happily in collaboration with our friends at Stanford, UC Berkeley, and also the San Francisco Department of Public Health. So the notion that the Bay Area is and could be and should be a hub for health economic analyses in a collaborative fashion is now being realized most prominently with this project, which we call CAPE. Various other examples of new projects and a very impressive publication list that you'll see. We're thrilled to be moving forward. We're busy thinking about next steps, and most of all, we're extremely pleased that this is a truly co-hosted conference with our friends from the Bay Area. And on that note, I will turn the mic over to one of them.
Thanks very much, Jim. I really just wanted to say thanks to all the people. We're delighted to be a part of this. Jim, thanks for inviting us, Kazi and Steph. Devin, of course, is really the brains behind this, but don't let that don't let Jim tell you otherwise. We have a fairly large community of people doing global health at Stanford, distributed in a lot of different centers. As Kazi said, I direct the Center for Health Policy, which is part of the Friedman Spogli Institute for International Studies. Also the Center for Primary Care and Outcomes Research, which is part of the Department of Medicine. In both places, we're actively engaged. Michelle Berry directs the Center for Innovation and Global Health, and I'm sure many of you know Michelle. And there are scholars throughout the university who are interested in global health and health more generally. And so we'd love to have any of you down. We look forward to collaborations, and we're going to learn a lot here today. And Jim, thanks very much.
Thanks to both. Thanks for not mentioning anything about trees or axes or bears or things like that, because I'm not good at that. It's great to be here. I'm sorry that Will Dow, who's a partner in crime on this, who's taking a sabbatical in Tokyo, can't be here with us. And what I'd like to suggest is that in any informal time that we have, and my email's on the website for the UC Berkeley School of Public Health, I see my role as being, in large way, the connector, the matchmaker. And I would very much like to help make matches between activities at Berkeley, activities here, and activities at Stanford, and activities at Davis, who isn't here, but we're also trying to work much more closely with them. Because very often I think that we have people who are working on a topic and don't realize what the complementarity might be. I just spent much of yesterday in a meeting of the Berkeley Food Institute. Turns out there are many health economics things that are very relevant to our food systems and nutrition, et cetera, but they don't think like health economists, and they don't even think about who they might talk to. So to the extent that I can help be that bridge, I've actually been asked to play that role by my chancellor, and we are just in the final processes of hiring somebody to help us bridge the two campuses more effectively. The initial part of that work will really focus on getting the administrative stuff out of the way, but along with that should be, hopefully, an expansion of academic collaboration. So if I can be of help, please don't hesitate.
Kazi and Jim asked me to talk a little bit about kind of a case study of where economic analyses helped inform policy questions. And so I'm going to talk about some work that we and others did on the cost effectiveness of HIV screening, and then how that eventually made its way into guidelines about screening and what kind of influence it had. And that's going to be sort of the case study that we'll talk about. And please jump in at any point with questions or comments. Just quickly, I think most of you know HIV, of course, a global problem with 33 million people or so now worldwide. And I want to sort of rewind. I'm going to talk a little bit about the screening guidelines and tell you where we are right now, and then kind of rewind back to, say, 2005. So right now, we have guidelines from a number of major groups. And prior to September 2006, the CDC recommended that people assess risk behaviors and screen high-risk individuals. I'm sure any of you were working HIV at the time, excuse me, remember that. And that people perform routine voluntary screening if the prevalence of HIV was 1% or greater. Now, the CDC recommends routine screening in all healthcare settings where the prevalence is greater than 0.1%. And so we're going to talk a little bit about today is how did they get from that earlier position to the current one. And now the United States Preventive Services Task Force also recommends screening in healthcare setting for the prevalence that's greater than 0.1%. And we have someone who's about to be the chair of the task force in the audience, Kirsten Bibbins-Domingo, who's right there and knows far more about this than I do. So if you get a chance, tell Kirsten hello and congratulate her on all the task force work. So let's go back to 2005. And at the time, the sort of paradigm was risk-based screening primarily unless you were in a high prevalence setting. And so the question was about whether screening should be expanded in some way. And there were several things that were driving that question. In and around 2005, about a quarter of people who had HIV were unaware. Fortunately, that number is not as high today, but a large proportion of people at that time were unaware of their HIV infection. More than half of HIV-infected adolescents were unaware. In a survey by the CDC, 80% of young MSM who were HIV-infected were unaware in 5 cities. So that was the setting back in 2005. The other thing that people understood at that time was that HIV infection was often being diagnosed very late in the course of disease. And the CDC surveillance at the time suggested that almost half of people really developed AIDS within a year of their diagnosis with HIV. And so for those of you who are not in the HIV world, HIV infection untreated, people probably lived 10 to 12 years before the advent of antiretroviral therapy. What that number means is that many of the people had been HIV infected for years and years and had not been diagnosed. Similar kind of thing at the VA where I work, 40% of people had CD4 counts less than 200 at diagnosis, indicating that they really had AIDS. Again, suggesting that people were being diagnosed very late in the course of disease. And the CDC at that time was estimating 20,000 new infections per year from people who did not know that they had HIV. So based on those, you certainly get the picture that what was happening at the time in terms of diagnosing HIV was inadequate. It really wasn't getting people identified early in their course of disease. So what I'm going to talk about, what they asked me to talk about, is sort of this case study, or 2 studies, one that we were involved in. These were cost effectiveness of screening. This is the first, Jillian Saunders and other colleagues who you may know that I was involved in. And then another analysis done by David Paltil and his colleagues at Yale and Harvard, good friends and close colleagues, and these were published together in the New England Journal in 2005. And so I'm going to talk about, they're both completely independent cost-effectiveness analyses of screening for HIV, and then I'm going to talk about sort of what the results were and then how this had some influence in terms of the screening guidelines. So I've alluded to this, 2 approaches to screening, targeted screening where you assess risk behaviors and screen if high risk, and so that's the group of risk behaviors that you would be trying to identify. And then routine screening where you'd offer screening to everyone. You might do it in particular settings such as STD clinics or homeless shelters that are high prevalence, TB clinics, et cetera. And in the early 90s, the CDC said 1% prevalence or higher, that's an area where you should do offer screening routinely. So why not? What were the issues with targeted screening? Why not just assess risk behaviors? Well, studies at the time suggested that 10 to 25% of people who had HIV reported no risk behaviors at all. And that might be because they are unaware or, of course, potentially that they didn't want to disclose those. And study at an STD clinic showed that if you only tested those people who reported high-risk behaviors, you'd miss about 75% of HIV diagnoses. And then there was concern that risk assessment was less likely to be reliable in the higher risk populations, the one in which you would most hope that a risk assessment would be useful. And these come in part from an analysis done for the U.S. Preventive Services Task Force back in 2005 by Roger Chow. Well, what are the issues with routine screening? Why not just screen everyone? There are a number, of course, medical harms, false positive results, stigmatization, cost, competing healthcare priorities. People have other things to do. Is really screening for HIV the highest priority. So in this context, we and other people looked at the cost effectiveness of screening, and now I'm going to take you through sort of the main results of the analysis and then talk about how screening guidelines evolve subsequent to that. Just as a quick reminder, some of you may not be in the business of doing cost effectiveness analysis. Cost effectiveness is a comparative exercise always. You're comparing two or more strategies, like screening to no screening. You assess the incremental benefit and the incremental cost of one strategy versus another. You calculate the incremental cost effectiveness ratio, which is the change in costs of the intervention and the change in benefits that you get when you do the intervention. So it's a comparative thing, and we're going to talk about the cost effectiveness ratio a little bit. So in terms of interpreting it, I hesitate to go here because no one will agree on any of this. But just to start with that. But here in the U.S., less than $50,000 per quality-adjusted life year gain, most people would consider that good value. You're not going to get much disagreement about that here. Obviously, that is a country-specific number. 50 to 100,000, I would say now, in fact, most people would still consider that to be good value. There's been a fair amount in the literature about what the cost-effectiveness threshold is or might be or should be, and we may hear more from Mark Sculfer later about how they think about this in the UK. Greater than $100,000 per quality, then people began to discuss whether or not this is efficient use of resources. So we looked at the costs and benefits of screening. We looked at the benefits both to the person that you identify and to the community if there's decreased transmission. If you find somebody who has HIV, you get them on therapy, you counsel them, they may be able to reduce risk behavior, so there may be a community benefit. We also looked at the costs, screening and counseling costs, and of course the costs of treatment. And at the time we did this, antiretroviral therapy was very early on. So certainly the amount of benefit that we calculated back then is low compared to what it would be now. We looked at two strategies, no screening, where you're only testing people who come in symptomatic, and that's really case finding, or HIV screening, where you do the case finding and you do one-time or recurrent screening in healthcare settings. So we developed a Markov model. This is a mathematical model where you project the course of disease under different scenarios. The details aren't important, but this basically allowed us to estimate the natural history of HIV with and without interventions. And you progress through different stages here. You can get on antiretroviral therapy. Back in those times, it was really reserved for people who are symptomatic or fairly far along. Of course, that's completely changed now. Current recommendations suggest that everyone should be on antiretroviral therapy. So let me talk now about the benefit that we estimated. Again, at the time, I want to emphasize this was back in the Zydavirdine day where antiretroviral therapy wasn't nearly as good as it is now. But take a look at this graph. This is the increase in life expectancy due to screening in years, and this is people's age. And I have two curves here. This is life expectancy. This is quality-adjusted life expectancy. And so what you see is that if you identified somebody in their 40s, they would live maybe a year and a half longer getting antiretroviral therapy earlier because they were screened. And this is not a comparison of no antiretroviral therapy to antiretroviral therapy. It's a comparison of finding people earlier, getting them on antiretroviral therapy earlier, consistent with the guidelines at the time. And so it would increase people's length of life around a year and a half or so. That's a substantial increase. For those of you who are not used to looking at changes in life expectancy, that's a fairly substantial benefit. That's the benefit to the person with HIV. Obviously, most people you're screening don't have HIV. And so let's look at the benefit overall. So what I'm going to show you here's the strategies, no screening and screening. This is the lifetime costs for each of the strategies, the incremental cost and the lifetime quality-adjusted life years, and the change in qualities, and then the incremental cost effectiveness. So what we see is if you screen people, It costs about $194 more per person screened, we estimated at that time. They would live about 5 days longer, quality adjusted life days. And that may seem small, but recognize what that means is that's an increment for every person screened. Of course, the people who have HIV get a big increment of a year, year and a half, something like that. Most people get 0. That's just the average when the prevalence is 1%. And for our purposes, what we were interested in is this cost-effectiveness ratio is $15,000 per quality. That would be considered good value by almost anyone. And so it really suggested that HIV screening, even with the sort of very limited antiretroviral therapy that was available at the time, was a reasonable thing. But I think the most important result was the following. So this is a graph that shows the incremental cost effectiveness of screening dollars per quality on the y-axis and the prevalence of HIV on the x-axis, from 1% to 0%. Remember at the time, the CDC's guideline was that you should do routine screening if the prevalence of HIV was 1% or greater. But what we show here is the cost effectiveness. This is with transmission included. This is if you exclude transmission benefits. It's clear, crystal clear now, although it wasn't as much at the time, that antiretroviral therapy prevents transmission. So take a look at this dotted line. And then if we just pick this $50,000 per quality line, we can look down and see what the prevalence is at which screening is cost effective. And that turned out to be 0.05%. Much, much lower than the CDC's threshold at the time. Our friends David Paul and colleagues from Yale and Harvard got a very similar result, and their analysis suggested that screening was cost-effective down to a prevalence of about 0.1%. The take-home from this here, though, is that screening was cost-effective at least at a prevalence 10 times lower than the CDC's threshold at the time. So to summarize, including transmission screening was cost-effective down to much lower prevalences than were recognized in the guidelines at the time. And we had done some work on the seroprevalence of HIV in healthcare settings. And back then, this suggested really that screening is cost-effective in virtually every healthcare setting. So the CDC was revising their guidelines for a number of reasons, much of which had to do with this issue that it was clear that screening wasn't working very well. Many people were being diagnosed late, and they were aware of these publications. They contacted us and David Paul from Yale, asked us to do some analyses for them, which we did do some additional analyses. The main point that we made to them is if you're going to have a threshold for routine screening, the one that you have now, 1%, is far too high, certainly in terms of cost effectiveness. And so we had those discussions with them. And again, the cost effectiveness was just one small piece in many other considerations that the CDC was recommending. So then what happened? The CDC released their guidelines in 2006. And here's the change. So it says the CDC recommends that diagnostic HIV testing and opt-out HIV screening be part of routine clinical care in all healthcare settings in an opt-out way. That was completely different than the prior guideline, which had really recommended primarily risk-based screening. In all healthcare settings, screening for HIV should be performed routinely for all patients 13 to 64. Providers should initiate screening unless the prevalence of undiagnosed HIV has been documented to be less than 0.1%. That threshold that they chose came quite directly from the cost-effectiveness analyses that David Paul and his group did and the folks that I was working with did. And so I think that there was an influence of the cost-effectiveness in terms of understanding at what point should you do risk-based screening versus going back to, versus doing routine screening. So that came out in about 2006. And then there were a number of other guidelines. I was involved in some of them. This is the American College of Physicians. And we did a guidance statement at the time where we recommended that if clinicians do routine screening. And again, we used the same kind of threshold that was identified in the cost-effectiveness analyses. And we also gave some advice about implementation, how you would figure out if your prevalence was above or below that. And the idea is if you tested 4,000 patients in a clinical setting and none of them had HIV, then the 95% confidence interval for prevalence would be less than 0.1%, and you could go back to a risk-based or more selective screening strategy. And then in 2013, so I started on the task force in 2012. Turned out HIV was up for consideration just as part of the routine reappraisal. We ended up giving a recommendation to screening routinely in healthcare settings, which was a change. The task force had previously had a C recommendation, which meant, selective screening. So that was a fairly substantial change for the task force. And we again used this threshold for sort of universal screening of 0.1% that came from the cost-effectiveness analyses. The task force doesn't really use cost-effectiveness to decide whether to do something, but in this case, I think it'd be fair to say it was helpful in understanding thresholds at which you might want to consider different strategies. So just to summarize, I think this was a situation where there were cost-effectiveness analyses, economic analyses that had come out at an opportune time because many guidelines were being reconsidered for other reasons. And the analyses suggest that there were substantial benefits to the HIV, the person with HIV, that there are also advantages to the community in terms of reduced transmission. And the thresholds at which routine screening is cost-effective were far, far lower than the guidelines at the time. And this has now made its way into policy statements from the CDC, the task force, the ACP, the American Academy of Pediatrics, the VA. There are probably other groups now. And we now have a fairly broad consensus about HIV screening in the United States, which I think has helped move that forward to some degree. So I think I'll stop there. Thanks again, Jim, for the invitation, and happy to entertain questions afterwards. Thank you.
We have time for a couple of questions.
Great studies. Two things, though, that really come to mind as being very interesting here. One is that CEA was used for policy, and in so many arenas, if you talk about CEA, people go, oh my God, the devil. We can't use economics
Death panels
to make policy, death panels. But the second thing that's really interesting to me is that in many other areas, we're moving away from routine screening towards personalized screening. Mammography is an area where, we did routine and now we want to make it personalized. So do you have any comments on the kind of the bigger picture?
Well, I don't want to overplay the role that this had, but I think that these, like the CDC was revising their guidelines for other reasons, but they did find these analyses useful. I think it is, so when people ask me, well, do you have an example where somebody actually used cost effectiveness? I don't have that many. We've done a lot of cost effectiveness analyses, but this is one. With respect to the personalized screening, I agree, and Kirsten may want to comment on this. We look very carefully on the task force at subgroups and try to figure that out. It's usually very hard to to develop the evidence base to understand whether or not you should do things differently. I was just asked to give a talk on personalizing guidelines for biology and stuff, and I'm not sure what I would say. I haven't said yes to that. And I know the work that you guys are doing is very relevant to this. But I think that the evidence base for customizing or personalizing guidelines based on subgroups is often hard to come by.
Since your study that was done, the cost of HIV treatment has changed to some extent, and I wondered how that had affected your results.
Both the costs and the benefits have changed. So the drugs in total now are more expensive than when we were doing that. The benefits are also far greater. We have not repeated this work. We did some stuff about 3 or 4 years ago, still suggesting it's very cost effective, 5 years ago probably now. But we haven't repeated this particular analysis. The benefits of antiretroviral therapy now are so extraordinary My intuition is that it would look at least as good, if not better, but we haven't done that analysis. Thanks very much.